So today we're going to do a little something different with the podcast. We're going to go through a couple of case scenarios around esophageal perforation. I think this will be a neat discussion, and hopefully the residents will get a lot out of this format. Just a quick disclaimer, there was a severe windstorm on the day we recorded this podcast, so try as I did, there's only so much that audio editing can do in final production, so pardon some of the wind noise that you'll hear over us during this podcast. So I'd like to welcome Dr. Haley Leesley to the podcast today.
Thank you for having me.
Haley, before we get started, can you just quickly go over your educational pedigree for us?
Sure. I have my undergraduate degree from the University of Illinois in Urbana-Champaign. I then went on to get a master's at Georgetown and then completed medical school at Tulane University before I started here.
Awesome. And where are you going to fellowship next year?
I'll be doing a thoracic surgery fellowship at the University of Texas Medical Branch in Galveston.
Congratulations on that. Let's get started with the first case then. So you have a 55-year-old male with a history of achalasia who presents to the emergency room with chest pain after undergoing an endoscopic procedure.
All right. I would begin with a history and physical exam, focusing on his presenting complaint, especially in relation to his recent procedure. And I would want to specifically know why he was having his procedure done. I would assess for any prior cardiac history. And on my exam, I would do a cardiopulmonary exam. I would examine for any crepitus along the neck or the chest wall, and I would palpate his abdomen.
All right, so the patient tells you that he routinely sees his gastroenterologist for dilation of strictures related to his achalasia. Immediately after the procedure, he experiences sharp chest pain that radiated to his back. He is hemodynamically normal, and on exam, he is able to easily converse without overt signs of distress.
Interesting. So, my suspicion here is highest for an iatrogenic injury. Iatrogenic perforations are the most common cause of perforations in the United States. So I would start my workup by first ensuring that he has adequate IV access, is started on fluid resuscitation, broad spectrum antibiotics. I would get an EKG and a chest x-ray just to make sure that this isn't something peri-procedural, not related to the procedure itself. And then I'd plan for a CAT scan with oral contrast.
Is there any role for endoscopy in this situation?
As the patient has just had an upper endoscopy and I'm concerned about a perforation, I think the first step would be to look for a perforation. So with that, I'd either do a CT scan or an esophagram.
So what value does a CT scan have over an esophagram?
So both are good studies to look for a perforation. I think the advantage of a CT scan is that it can help identify masses, an abscess, effusion, or drainable collection that may need additional therapy, and so in my mind, that's the preferred first-line diagnostic modality. An esophagram will certainly give you the information about a perforation, and it's a dynamic study, but it's really limited to evaluating the esophagus alone.
Do you start antibiotics up front?
I would. My suspicion's fairly high in this case, and the morbidity and mortality is really related to timing of source control, so I would start antibiotics.
And what antibiotics would you start him on?
I would pick broad spectrum antibiotics that cover the oral flora as well as mouth anaerobes.
I know a question that sometimes comes up is covering these patients with antifungal coverage. Is that a recommendation that you would have?
I think that's a really interesting question, and I think that it is a little bit cultural and provider dependent. There's some indication that having yeast grow in your blood or yeast grow in your cultures is more a marker of a poor host response to a major insult such as a perforation. So I think it would be a case-by-case basis.
All right, so you've started fluids and antibiotics. The patient underwent a swallow study, which demonstrated a contained perforation in the distal esophagus right above the GE junction and projecting about 1 to 2 centimeters into the mediastinum, but appearing contained with no leaking into the pleural cavity. What is your next step in management?
I think there are two appropriate options here. You have a stable patient with evidence of a contained leak, so medical therapy alone, and by that I mean antibiotics, fluid resuscitation, and close monitoring for worsening signs of sepsis, is one available option. The other approach, and the one I would be more likely to choose, would be to take the patient for an esophageal stent. We know that the reason for the original endoscopy was for benign disease, so in this case, I think doing a covered metal stent would make sense for him.
All right, great. Thanks for laying out both of those options. So we get the patient an esophageal stent. Now, how would you monitor this patient in the hospital, and what are some specific considerations?
Sure. So I would continue broad spectrum antibiotics. I would assess the patient with a daily chest x ray to evaluate for a new effusion to suggest leaking not contained by the stent. My plan would be to repeat a swallow study in the next day or two to verify the appropriate position of the stent and to confirm that there's no further extravasation of contrast.
So yeah, I think that's a good point. Do you want to mention a little bit about stents and migration? It seems like our local experience too is there's been issues with these stents migrating and having to have our GI colleagues help reposition these stents. What's been your experience and recommendation for this?
So it's actually the most common complication after placing a fully covered self-expanding stent is migration. There's some data suggest somewhere between 30 and 60% of stents migrate. And given that this is for a perforation, it's really important that this stays in appropriate position. So something that can be done is just placing a stitch on the superior or the upper flap of the stent can help anchor it into position.
What you mentioned too about advancing their diet, are you always able to give the patient a diet? Do they just have to stay on a clear liquid diet? Can they advance, or should we be thinking about TPN for these patients for a short term?
Yeah, that's a great question. In this case, this patient was healthy at his baseline and went for an elective procedure for benign disease. So I think that if you verify the stents in good position, I would start a clear liquid diet and advance to a regular diet. I would not start TPN. I would plan for a total of 10 days of antibiotics with a plan for removal of the stent in 2 weeks.
All right, let's move on to the second case. So the first one, we had a contained leak that we were able to manage with an esophageal stent. Now let's say you have a 72-year-old male who presents to the emergency room complaining of substernal chest pain radiating to his back. He reports that he was eating steak shortly prior to presentation when he felt a choking sensation and subsequently had a coughing fit. On exam, he's tachypnic, tachycardic to the low 90s and requiring 2 liters of supplemental oxygen. He's currently afebrile. He has crepitus extending from his neck along his right chest, and his abdomen is non-tender.
Okay. Well, this patient is clearly less well than the last patient. Given the history of obstructed food bolus leading to chest pain, I'm again concerned about an esophageal perforation. However, in a 72-year-old gentleman presenting with chest pain, you still have to work up cardiac and pulmonary causes.
So tell me a little bit more about your workup.
Okay. Since we have a good history in physical here, I would start with my lab work, including a CBC, BMP, lactate, and troponin. I would also get an EKG, a chest x-ray, and then a CTA dissection study as well as with oral contrast.
So your EKG is unremarkable. He has a leukocytosis of 12,000. His BMP is notable for decreased bicarbonate and a lactate elevation to 3. And the CTA demonstrates extensive pneumomediastinum with an air fluid collection in the lower esophagus, suggestive of a perforation.
All right. Given this concern for a perforation, I would again ensure that this patient has adequate IV access, start fluid resuscitation, and broad spectrum antibiotics. His clinical history is interesting. It does match with our understanding of esophageal perforations in that spontaneous ruptures without clearly identifiable pathophysiology are often related to these sudden increases in intra-abdominal pressure, as in with this patient with a food bolus that he then tried to cough up, or so coughing or retching that create that pressure can cause tears in the esophagus.
Is there a location that esophageal perforations happen most commonly?
In that case, for a spontaneous perforation, it's typically in the lower esophagus.
But a rupture can occur elsewhere, correct?
Yes, so you can have the majority, 70 to 80% of esophageal ruptures occur in the thoracic esophagus, and then about 15% occur in the cervical esophagus.
And this is important in terms of...
When you're thinking about how you're going to approach the patient operatively, it's important to think about where your perforation is. This affects patient positioning.
All right, that's a great point, and I think you're going to get to a little bit more of that in a minute, but what's your next step for this particular patient?
Well, I'm concerned that this patient has a free perforation, and in that case, medical therapy alone is not sufficient. He not only has a perforation in the esophagus, but also appears to have contamination in the pleural space, as seen on his CT scan. So my goal is to get source control as quickly as possible to prevent mediastinitis and overwhelming sepsis. So my plan would be to take him to the operating room.
All right, let's just go over some of the current operative strategies you have available.
There are actually a lot of strategies that you can do. So the current therapy includes drainage alone, so either doing a thoracotomy with drainage or placing a chest tube. So decortication drainage, drainage alone. You can do primary repair with a tissue buttress. You can repair the injury over a T-tube with the idea being to create a controlled fistula, or you can do an esophageal resection or esophageal exclusion. And I think the operative approach really depends on the patient's hemodynamics, the presence of other pathology, and the suitability of the esophageal mucosa at the time of operation.
So I think when you're presented with this and you've gone over these operative approaches nicely, how does that factor in your discussions with the patient?
It's important that if the patient is awake and oriented, that they understand that this is a very morbid pathology. The overall mortality rate is 20%, with the lowest rate of mortality being after iatrogenic perforation, about 10%. But in his case, with post-emetic perforation being as high as a mortality rate of 60 to 70%. And really the biggest factor that increases mortality is your time to source control. So there's early perforations, which are considered within 24 hours, and their mortality rate is somewhere between 10 and 25. And then after 24 hours, where it's as high as 60%. So it's important to talk to them about if you're not able to primarily repair the esophagus in the operating room, that they may end up with a spit fistula or an esophagectomy or require further surgery in the future.
Could you talk a little bit more about a primary repair?
Yeah, I think in this patient with no underlying esophageal pathology, at least that we know of, and a good history for the trauma that ensued leading up to his perforation, I would try first for a primary repair. I think that that should be tried first in most cases. Even with sizable perforations, it's really more about the circumferential perforation rather than the length. And you want to be able to assess for a healthy esophageal tissue, and by that I mean the mucosa. I would buttress my repair. You can buttress that with a couple different types of tissue. You can use the pleura itself if it's not too contaminated and necrotic. You can use pericardial fat, or you can harvest an intercostal muscle flap on your way into the chest.
Is one of these easier than the other?
I think the easiest is probably harvesting an intercostal muscle flap, because once you have contamination, you have such a profound inflammatory response around the tissue that pleura, pericardial fat might have all necrosed as well.
All right, so the plan is going to be to take this patient to the operating room. Can you tell me a little bit more about the setup and conduct of the operation?
Yes. So in this case, since this is a lower esophageal perforation and we saw contrast leaking into the left chest, I would plan for a left thoracotomy. I think the positioning of your patient really depends on where you suspect the perforation is, and one of the easiest ways to tell would be on your contrast esophagram or your CT to see where you see contrast leaking out to help determine the site. In general, it seems that upper thoracic and lower thoracic esophageal perforations are best treated with a left thoracotomy, whereas mid-thoracic is treated with a right thoracotomy. But once we're in the operating room, for him, we'll do a left thoracotomy. I would make sure that he has adequate access, arterial monitoring, and I'd plan to intubate with a double lumen tube or a bronchial blocker, either of which is able to help us achieve lung isolation. And then I would start with an on-table EGD.
Great. So on EGD, you see a 5 centimeter area of perforation from 28 centimeters to 32 centimeters above the GE junction. You can see in the thoracic cavity as well.
All right, so we know we have a free perforation. We have a length of the perforation. Fortunately, it's above the GE junction. So I would plan to put this patient in the right lateral decubitus position. I would perform a left posterior lateral thoracotomy. On entering, as I said before, I'd harvest my intercostal muscle flap. I'd start with one. You can always go back and get a second muscle flap if you feel like you need more coverage. The principles here are to make sure you debride the necrotic muscle and tissue, and so you can isolate the area of injury. Oftentimes, it's difficult to see the full extent of the mucosal injury, so you have to elongate the myotomy and debride the necrotic edges so that you are ensuring that you come back to healthy mucosa. Once you have that, if the mucosa looks viable, then I would close it with a 4O PDS in a running fashion and perform a leak test.
All right, so you perform your leak test with insufflation and you don't see a leak. So what's next?
So now I would do my buttressed tissue repair, and then I would place 2 chest tubes, one probably along the site of perforation and then one just into the pleural space, and verify that I have an NG tube in position past the site of perforation. Then I would take the patient to the SICU.
Great. What's your expected postoperative course for these patients?
The postoperative care is really supportive. It should be in a critical care setting where you can have good hemodynamic monitoring, cardiac monitoring, and respiratory support. I would keep the broad spectrum antibiotics for at least 7 to 10 days. I would continue NG tube decompression of the stomach until minimum you have resolution of your ileus, at which point you can start enteral feeding. I would do a contrast study on the 5th day, and this is really just to document the integrity of your repair. And then long term, these patients should be followed for stricture formation, reflux, or for a cancer.
Great. Is there anything specific about chest tube maintenance up front, or is this something that stays until their swallow evaluation, or when can you take these chest tubes out of these patients?
I think the chest tube management should be on a case-by-case basis, looking at the character and the quantity of the output that you have. I would leave a chest tube in place until after I'd started this patient on a diet.
Awesome. Well, I appreciate you going through these cases. I think it's a nice format to help residents kind of get an idea about the workup and management of esophageal perforations. So thanks for joining us on the podcast today.
Thanks for having me.
So thanks again to Dr. Haley Leesley for joining me today to discuss esophageal perforations. Next week, we'll be continuing our chief podcast project with Dr. Lily Wang on the management of carotid disease. Stay tuned for that and other upcoming chief podcast discussions on how residents can better prepare for teaching cases and aortic atherosclerotic disease. We will also be doing a special podcast takeover in a few weeks with some of our previous Brown Critical Care Fellows and faculty, so be on the lookout for that. Have a great week, and I'm looking forward to having you back with us in the next episode.